Welcome, curious minds, to another deep dive. Today we're embarking on what really feels like a medical detective story.
Mm-hmm.
We're talking about those, unexpected moments when what seems like a routine procedure suddenly uncovers something hidden, something that completely shifts the landscape.
Absolutely. A real curveball.
We've compiled some incredibly detailed source material on incidental gallbladder carcinoma, discovery and diagnosis. So our mission for you today is pretty straightforward. Give you a clear, concise understanding of this complex process.
Yeah, sort of a shortcut to being well informed.
Exactly, with maybe some surprising facts
Hmm.
and just enough insight to keep you hooked.
Indeed. We're going to guide you through that intricate journey, right from a gallbladder that seems perfectly fine to a life-changing diagnosis.
It sounds like a story where vigilance, in the OR and meticulous detail in the pathology lab are just paramount.
They really are. We'll explore how these incidental cancers are actually found, what critical clues surgeons and pathologists are looking for, and crucially, how these discoveries then map out the entire course for treatment.
So the idea is you'll walk away with a really clear understanding of the key decision points, those vital reports, and the staging system that ultimately guides, well, the patient's destiny.
And what's truly fascinating here, I think, is how many layers of human expertise, technology, and just sheer observational skill have to come together to uncover and then address a challenge like this.
Okay, let's jump right in then with that initial moment of discovery. Picture this. A patient is undergoing a routine laparoscopic cholecystectomy that's the standard minimally invasive gallbladder removal.
Very common procedure.
Right. Everything seems normal, but then this seemingly benign organ, it holds a secret. An incidental carcinoma. It's the kind of twist nobody expects.
It truly is a pivotal moment, and that term incidental is so key here. It means the cancer just wasn't suspected beforehand, which makes every subsequent observation and every decision incredibly crucial. The whole medical team has to pivot instantly.
And even when it is incidental, our sources tell us that really sharp surgeons can often spot clues during the operation itself, like subtle red flags, right? Picked up by a highly trained eye.
Precisely.
What are some of those early warning signs a surgeon might notice?
Well, this really highlights the paramount importance of surgical vigilance. You know, the surgeon isn't just performing a mechanical task, they are actively observing, feeling the organ. So for you, the listener, some key details to grasp include maybe a thickened or nodular gallbladder wall. Imagine like the smooth texture of a balloon suddenly feeling kind of lumpy or rigid.
Okay.
That's a subtle change, but it's a significant warning.
So it's not just what they see, it's also about how the tissue feels. That sounds like it requires immense experience.
Oh, absolutely. Another red flag could be what's called a frozen Calott's triangle, or porta hepatis.
Okay, what does that mean, froze?
So imagine the gallbladder sitting in its usual spot, connected to the liver, the bile ducts. Around it are these critical structures, areas like Calott's triangle, the porta hepatis, they're like anatomical crossroads.
Got it.
If these areas feel unusually rigid or immobile to the surgeon's touch, instead of being sort of soft and supple, that's a big warning sign. It suggests the cancer might be hardening the surrounding tissues, maybe starting to infiltrate.
Wow.
Or you might see what looks like an empyema-like gallbladder. It looks like it's full of pus, but when they actually touch it, palpate it, it feels unusually firm. That firmness is the clue.
Okay.
And finally, maybe dense adhesions that resist dissection. These are bands of scar tissue. If they're unusually thick and really difficult to separate from surrounding structures, that suggests there's an underlying issue, perhaps the cancer causing things to stick together abnormally.
Those are incredibly subtle cues. So if a surgeon does pick up on any of these, what's the immediate next step, in that high-pressure OR setting?
Right, and here's where it gets really interesting for the medical team. Our sources share a vital pearl. If that suspicion arises, the surgeon should immediately request a frozen section.
A frozen section, while the patient's still on the table.
Exactly. It's a rapid pathological diagnosis, gives you near real-time answers. And interestingly, in areas where gallbladder cancer is more common, they call them endemic builds.
Uh-huh.
Suspicious findings might even warrant converting right then and there from a minimally invasive scope procedure to an open procedure, just to get a better look and potentially act immediately.
That's incredible foresight. And, it reminds me of that striking aphorism from our sources. Many incidental cancers were visible but invisible to the distracted surgeon.
That says it all, doesn't it?
It really emphasizes focus, experience. It's not just looking, it's seeing.
Absolutely. But ultimately, no matter what the surgeon suspects or sees, pathology is the final arbiter.
Right.
This is where the tissue, once it's removed, gets examined under a microscope for the definitive diagnosis. It's the ground truth.
And what are pathologists primarily looking for when they examine these specimens? Are all gallbladder cancers the same under the scope?
Oh, not at all. And understanding the differences is absolutely key. Over 90% of these incidental gallbladder cancers are adenocarcinoma. That's the main type.
Okay.
But even within that, there are different histological types. And knowing which one it is, well, that's crucial for prognosis, the patient's outlook.
So different types mean different prognosis.
Exactly. For instance, the papillary type, it's described as exophytic, meaning it grows outwards, kind of like a cauliflower.
Okay.
This growth pattern generally carries a better prognosis, a more favorable outcome.
That's good to know.
Yeah. In contrast, the mucinous type is often more aggressive. And then you have rarer types like adenosquamous or squamous carcinomas, which unfortunately tend to be associated with a significantly poorer outcome.
So if you're listening, the key takeaway here is that not all cancers are created equal, even in the same organ. And drawing from our sources, if we had to pick one, which histological type has the best prognosis?
That would be the papillary carcinoma. It's a really critical distinction for patients and clinicians alike because it directly impacts the outlook and helps guide the treatment strategy.
Okay. Now, beyond just the type of cancer, our sources really stress that a comprehensive pathology report is absolutely crucial. It's not just a yes or no on cancer, right? It's more like a detailed case file.
Exactly. A blueprint for all subsequent decisions.
So what are the absolute non-negotiables? What must that report include?
Right. The pathologist is looking for several critical clues or data points. First, the depth of invasion, literally how deep has this cancer tunneled into the gallbladder wall?
Yep, depth.
Then, the cystic and liver bed margins. Think of these as the cut edges of the removed tissue.
Are they clean?
Exactly. Are the edges clear of cancer cells, especially where the gallbladder connected to the bile duct, the cystic duct, and where it sat against the liver? Did the surgeon get it all out? Absolutely. The report also must explicitly mention lymphovascular invasion. That means, have cancer cells gotten into the small lymphatic channels or tiny blood vessels?
Like escape routes?
Pretty much.
Yeah.
Have they found a highway system to potentially spread? And similarly, perineural invasion has it spread along nerve fibers, another subtle route.
Okay.
And finally, the grade of differentiation. This describes how abnormal the cancer cells look compared to normal gallbladder cells. Are they well-behaved, looking somewhat normal, or are they really chaotic and angry-looking?
Which tells you how aggressive it might be.
Precisely. It gives an indication of how aggressive the cancer is likely to behave. Each piece of this information shapes the next move.
So once we have that incredibly detailed pathology report with all those elements, how's all this information compiled and used? How do you translate that into a unified plan for treatment?
This is where the AJCC 8th edition staging system comes in. Think of it like a universal language for describing the cancer's extent.
Okay, a standardized system.
Exactly. It classifies the cancer based on its characteristics, and it guides all subsequent decisions. Let's maybe look at the T stage first that describes the tumor invasion itself. How far has it grown locally?
Right, the T for tumor. And within that T stage, what are the really pivotal thresholds, the turning points that drastically change the game?
Well, probably the biggest leap in the T stage is often going from T1 to T2.
Okay.
TIS means carcinoma in situ cancer cells just in the very top layer, no real invasion yet, contained.
Right.
T1 means the cancer is still largely contained within the gallbladder wall itself. So T1A invades just beneath the top layer, the lamina propria, and T1B invades into the muscle layer, still within the wall.
Okay, still relatively contained.
Exactly. That often means a different, sometimes simpler treatment path, but T2 signifies it's grown into the connective tissue beyond the muscle layer.
Okay, it's broken out of the main wall.
Right. And crucially, within T2, there's a vital distinction our sources emphasize. T2A means it invades the connective tissue on the peritoneal side, that's the outer side, facing the abdominal cavity.
Whereas T2B invades the connective tissue on the hepatic side, the side sitting right against the liver.
And why is that distinction so important?
Well, that T2B finding is critical. It generally behaves much more aggressively than T2A, which we'll touch on more. Beyond T2, you get to T3, where it's actually broken through the outer layer, the serosa, or it's invading the liver directly, but just a little bit, 2 centimeters or less, or maybe invading one adjacent organ.
Okay, definitely spreading.
Yeah. And then T4 is the most advanced local stage. It's invaded major blood vessels like the portal vein or hepatic artery or multiple adjacent organs. Really extensive local disease.
That paints a very clear picture of the local spread. Now, what about the other letters in T and M, the N and M? Where might it have spread beyond the gallbladder itself?
Right. N refers to regional lymph nodes, the nearby drainage basins.
Yeah.
N0 means no cancer cells found in those regional nodes, which is obviously good news.
N1 means metastasis is found in 1 to 3 of those regional lymph nodes, indicating some local spread. And N2 means it's in 4 or more regional nodes, showing more extensive spread within that local basin.
Okay. NM.
M is for distant metastasis. Has it spread far away? M0 means no distant metastasis found. M1 means distant metastasis is present. The cancer has traveled to distant organs like the lungs or maybe other parts of the abdomen.
Got it. TNM tumor, nodes, metastasis gives you the whole picture. Now, you mentioned a pearl about T2A versus T2B being incredibly important. Can you expand on why that subtle difference matters so much?
Yes, it's a crucial point from our sources. Invasion on the hepatic side, the liver side, which is T2B, it just behaves significantly worse than invasion on the peritoneal side, T2A.
Why is that?
Well, think about it. The hepatic side of the gallbladder is basically glued right onto the liver. So it offers a much more direct, almost easier pathway for the cancer cells to invade directly into the liver tissue itself. This subtle anatomical difference has major implications for prognosis and treatment planning. Often, finding T2B disease requires a different, more extensive surgical approach compared to T2A.
Okay, that makes sense. So the incidental cancer is found, it's meticulously looked at by pathology, precisely staged using TNM. What happens next before any potential second surgery? What's the workup?
Right, so before any decision about reoperating, a thorough staging workup is mandatory, non-negotiable.
Okay.
This is to make absolutely sure the team has the complete picture of any potential spread. It usually involves several imaging techniques. A CECT, that's a contrast-enhanced CT scan of the abdomen and pelvis, that looks closely at the local area and the lymph nodes.
Standard stuff.
Pretty standard, yes. Then MRI or MRCP, that's magnetic resonance imaging, specifically good for looking at the bile ducts if biliary involvement is suspected. In some select cases, a PTCT scan might be used. That's particularly good at detecting distant spread that other scans might miss.
Okay.
And finally, tumor markers blood tests like CA19-9 and CEA. These give a baseline reading, which can be really useful for monitoring how things are going after treatment starts.
But the scans aren't the end of the story, are they? Our sources mentioned something else, another crucial step.
No, they aren't. And this is where it gets really interesting and frankly quite important. Our sources strongly emphasize a crucial step, performing a staging laparoscopy before committing to any major re-resection surgery.
A staging laparoscopy, so another keyhole surgery, just to look around. Why is that necessary after all those scans?
It seems counterintuitive, right? But it's done specifically to detect tiny peritoneal, that's the lining of the abdomen or liver surface disease, that even the best, most advanced scans often miss. These can be like tiny seeds scattered around. And here's a really sobering statistic from our source material. Up to 25 to 40% of patients who otherwise looked like candidates for curative surgery based on scans are actually found to be unresectable at this staging laparoscopy.
25 to 40%, that's huge.
It is. It means the disease has already spread too far, usually with those tiny peritoneal or liver surface mets. So this second look literally saves those patients from undergoing a huge, unnecessary major operation that wouldn't actually cure them. It allows the team to pivot maybe to chemotherapy or other palliative approaches instead.
That's a really powerful argument for that extra step. It really echoes that other aphorism we found. Never reoperate blind. Staging laparoscopy is your second sight.
Exactly. It's about seeing the unseen, making sure you're not embarking on a massive surgical battle if the war has already spread elsewhere undetected.
Okay, so after all this careful discovery, pathology, staging workup, including the laparoscopy, the surgical plan itself, if surgery is still on the table, really hinges on what?
It really boils down to two main things: the margins from the initial operation and the extent of nodal spread found during staging and potentially confirmed during surgery. These dictate the extent of any subsequent surgery, often that reoperation we mentioned.
Okay, let's talk margins first.
Yeah.
If those initial margins weren't clear, say, the pathologist found cancer cells right at the edge of where the surgeon cut, what's a typical next surgical step?
Good question. If the cystic duct margin is positive, meaning cancer cells were found right at the edge where the bile duct connecting to the gallbladder was cut,
Oh.
it typically requires going back in to excise more of the bile duct. Sometimes this even requires a complex reconstruction called a hepatocgenostomy.
Which is?
It's basically creating a new connection, a bypass, directly from the main bile duct coming out of the liver to the small intestine to ensure bile can still flow properly. It's a significant follow-up procedure.
Okay, quite involved. What if the liver bed margin is positive, where it's sat against the liver?
If the liver bed margin is positive, meaning the cancer might have just started to nudge into the liver surface itself or was right up against it, surgeons often need to go back in. They perform a more extensive removal, typically taking a wedge or even a formal segment, a specific anatomical section of the adjacent liver tissue, usually segments IVB and V.
So taking a piece of the liver.
Exactly. It's like having to cut a wider safety perimeter around that problem area just to be absolutely sure you've gotten it all.
And conversely, if the margins were clean from the first operation.
That simplifies things a lot. Negative margins generally mean there's no need for a routine bile duct excision or major liver resection just based on the margin status. The focus then shifts more heavily to the nodal status and the T stage.
Okay, let's talk nodes then. How does the extent of nodal spread, the end stage, inform the surgical strategy?
Well, understanding the typical pattern of spread is key. The first lymph node cancer cells usually travel to from the gallbladder is often called the cystic node of Lund. Think of it as the main sentinel lymph node for the gallbladder.
The first stop.
The first stop, typically. From there, it can spread sequentially to nodes along the main bile duct, pericholedocal, then along the hepatic artery, the portal vein, up towards the celiac axis, and eventually even the para-aortic nodes way in the back.
A predictable pathway, sort of.
Generally, yes. So during the staging workup, and especially during any reoperation, assessing these nodes is critical. To ensure an adequate assessment and accurate staging, our sources indicate that harvesting at least 6 lymph nodes during the surgery is considered a key quality indicator.
6 nodes. Why that number?
Getting at least 6 gives the pathologist enough tissue to get a really good handle on whether the cancer has spread to the regional nodes and, if so, how extensively. It's essential information for determining the final stage and guiding decisions about further treatment, like chemotherapy.
Wow, what a journey we've taken from that unexpected finding to the detailed staging and surgical planning. It really highlights the incredible teamwork and precision involved, doesn't it?
It absolutely does. From the vigilant surgeon's touch in the OR, to the meticulous pathologist's eye at the microscope, to the radiologist interpreting scans, and then back to the surgeon planning the next step. It's a real testament to how many layers of expertise come together for one patient.
Let's maybe try and quickly recap the absolute key messages from this deep dive, the things you really want to take away.
Okay, good idea. Think of these as the essential nuggets. First, incidental gallbladder carcinoma often does have intraoperative hints. Vigilance in the OR matters immensely. Don't be distracted.
Right, see the subtle signs.
Second, pathology is king. The tumor type, the depth of invasion, the margins, lymphovascular invasion, perineural invasion, the grade. All these details define the subsequent treatment plan.
The blueprint.
Exactly. Third, the AJCC 8th edition staging guides all decisions. And remember that crucial difference between T2A, the peritoneal site invasion, and T2B, the hepatic site invasion. T2B has a worse prognosis.
But T2B distinction, yeah.
Fourth, always restage thoroughly with imaging and that crucial staging laparoscopy before any planned reoperation. Don't operate blind.
Second sight.
That's the one. And finally, achieving clean surgical margins and understanding the extent of nodal spread are absolutely critical determinants of long-term survival.
Those are great takeaways.
Yeah.
You know, it really drives home the complexity, but also the structured approach medicine takes.
It does. And maybe to leave you with one final thought, another aphorism from our source material that I think really encapsulates this whole discussion. Incidental gallbladder carcinoma is discovered by pathology, but its destiny is written by the surgeon.
That's powerful. It really brings home that intersection of meticulous diagnostics, the discovery, and then the strategic art and skill of surgery, the writing of that destiny.
It speaks volumes about the responsibility, doesn't it? Bringing the science and the skill together to try and shape a patient's future.
Indeed. Understanding these intricate layers of discovery and diagnosis, well, it's just the beginning of that journey for the patient and the medical team.
That's right.
We've seen how to recognize and stage incidental gallbladder carcinoma. I've got the blueprint, the staging, but this leaves us wondering, naturally, once all this information is gathered, once that destiny is sort of charted out what are the actual surgical strategies. What does that destiny look like in practice for these patients? How do surgeons go about writing it?
A crucial next chapter.
Absolutely. Well, thank you for joining us on this deep dive. We really hope you feel incredibly well informed now, maybe even a little inspired by the sheer precision and human expertise involved in these critical medical journeys.